Well, thank you for that wonderful introduction. Can you guys hear my voice if I don't lean over? Okay, I can speak really loudly if you need me to. What a terrific session. Thank you to Annette and the whole Global Health team for putting on this terrific event. You've heard Archana, and probably earlier, I didn't hear you talk, Baraj, speak about a number of different activities that are ongoing in Nepal in the cardiometabolic sphere. So I'm going to focus on something a little different. I'm going to just talk about rheumatic heart disease. So I have nothing to disclose, but just to note that the study was funded by several NIH grants, University of Washington, as well as Sonosite. One of the activities, we needed ultrasound machines, and Sonosite was very generous to provide us with these ultrasound machines. So for those of you not familiar with rheumatic heart disease affects 40 to 100 million individuals globally. It's the most important form of acquired heart disease in children and young adults in lower and middle income countries. It accounts for 15% of all patients with heart disease in endemic regions. Estimates range from 320,000 to 1.4 million deaths annually. More common among females and is the leading cause of obstetric deaths in endemic countries. Rheumatic heart disease is a disease of poverty predominantly, affecting populations in lower and middle income countries. In Nepal, kind of see where Nepal is, most of you know very well where Nepal is, has one of the highest burdens of rheumatic heart disease. While the improved living standards, access to healthcare, and widespread use of penicillin have alleviated the disease burden of RHD globally, it still remains high in the subcontinent and particularly in Nepal. So briefly, and I apologize, a few of these slides are a little not optimal after eating, so close your eyes. So for the rheumatic heart, for the non-physicians, what is rheumatic heart disease and what's its pathophysiology? RHD is a long-term sequelae of acute rheumatic fever, a condition that's caused by autoimmune reaction to group A strep. Antigenic mimicry, along with abnormal host response, is considered the key to the pathogenesis of RHD. Up to 3% of people with group A strep pharyngitis, so that's what we call strep throat, go on to develop acute rheumatic fever. Acute rheumatic fever is characterized by fever, abdominal pain, subcutaneous nodules, rash, joint pains, chorea, which is almost like a dance-like movement, and most importantly, in my mind, cardiac inflammation. Mortality rate without antibiotics is 1.5%, and 64% of patients with acute rheumatic fever go on to develop rheumatic heart disease. Chronic RHD is characterized primarily by disease of the heart. The biggest impact of RHD is on the heart valves, where progressive valve damage occurs over time. The mitral valve is most commonly the valve affected. Recent studies suggest that almost 14% of RHD patients develop heart failure within a year of diagnosis. And part of this is because most people who get diagnosed with RHD get diagnosed symptomatically. They come with symptoms. And this increased to 27% in 5 years. And in addition to heart failure, RHD leads to atrial fibrillation and stroke. It leads to infective endocarditis, leads to death. And it's particularly devastating because much of this morbidity occurs in teenagers and young adults. You know, when my first visit to Nepal, I think it was almost 10 years ago now, we met a patient in the ICU who had just had a devastating stroke, and he was only 19 years old. So the mainstay of therapy is penicillin or other antibiotics. So penicillin is used first to treat the strep throat. is to treat acute rheumatic fever. And then monthly prophylactically, antibiotic shots are given up to age 40 to prevent reinfection and further damage of the heart valves. So there's a whole number of knowledge gaps that we have. And we hope that some of our work in Nepal will help address these knowledge gaps. I'm not going to talk about these. I just want to highlight one of the activities that we're doing in Nepal. And that's finding a screening method to identify more individuals earlier who will benefit from prophylactic antibiotic use. Currently, most patients are diagnosed with RHD when they come to attention at a late stage when they have symptoms, either symptoms of advanced heart failure or some other sequelae of RHD. And so they're really we're missing that window of early treatment. Gone the wrong direction. So Nepal is an ideal setting to conduct an RHD screening study. While the epidemiology is not fully understood, prevalence in school-aged children ranges up to 3%. RHD accounts for 2% of deaths in young adults. There's no systematic or comprehensive program of RHD screening, with screening occurring occasionally, primarily in school-aged children. So missing the opportunity to capture young adults. But on the plus side, there is strong government commitment to RHD care, and it remains a public health priority. So with funding from the NIH and the UW, we sought to screen first-degree relatives of RHD patients to see if we could identify latent RHD. What motivates this work is two screens to look at. So I apologize that I have most of my back to you guys. So what motivates this work is that first-degree relatives of RHD patients share known risk factors for RHD: poverty, poor living conditions, crowding, poor hygiene, shared genetics. All of these are risk factors for RHD that are shared among families. A prior study in Uganda that Chris is probably familiar with found that there's high rates of rheumatic heart disease among first-degree relatives. And the main motivation, again, is to identify a high-yield screening method that may allow timely preventive measures. So our objective was to determine whether screening first-degree relatives provides this high-yield screening method that we're searching for. We performed a cross-sectional study based at two tertiary centers in Nepal, Dolkhel Hospital and Manman Cardiothoracic Vascular and Transplant Center, both in the Kathmandu Valley. RHD cases that were enrolled in our RHD registry were given the opportunity to invite their first-degree relatives who didn't have clinically recognized RHD to come in for RHD screening. Screening was performed by our Nepali cardiologist colleagues. Studies were then uploaded and transferred to UW. Rajan Arshad, do you recognize the cardiologist there? That's 10 years ago, different hair color now. So a committee of cardiologists and echosonographers here at the UW reviewed each echo and adjudicated presence of RHD using the World Heart Federation classification. And what's the World Heart Federation criteria? So the WHF categorizes RHD into definite RHD, particularly when there's either pathologic regurgitation or stenosis of the mitral or aortic valve, as long as there's also other morphologic features consistent with RHD. For those under 20, there's also a category of borderline RHD for those with concerning abnormalities on the valve, but not meeting the strict criteria necessary for definite RHD. And what you see at the bottom is an echocardiographic image of RHD where the mitral valve is stenotic and the valve leaflets give that classic hockey stick appearance. Of the 102 index cases, they had a mean age of 30 and they were predominantly women. 6% had a known family history of RHD. And of note, 90% were symptomatic at the time that they were themselves diagnosed. Among the 234 FDR screened, so looking at the first column, 19 had either borderline or definite RHD for a prevalence of 8%, and 3% of them had definite RHD. Now, because penicillin antibiotic is given only until age 40, we did a secondary analysis where we just limited the FDRs to those younger than 40. And so that's what you see in that second column. So among the 173 FDRs who were younger than 40, 11% had borderline or definite RHD and 5% had definite RHD. And no one older than 40, no FDR older than 40 had RHD. And that's probably because RHD tends to get worse with age. And if they did have RHD, they would have probably been symptomatic by that time. So comparison with other screening methods. In order to compare our prevalence among FDRs with current largely school-based screening methods, we redid the analyses, this time now only looking at the FDRs up to age 15. We found that 19% of our younger FDRs had either evidence of either borderline or definite RHD. Compare that to the current school-based screening methods, where 0.1 to 3% of children in Nepal are screened positive for RHD. So our FDR screening method, certainly by comparing to what's currently being done, is high yield. We next looked at to see whether certain familial relationships were more likely to screen positive for RHD. We found that the 52 child-parent relationships where the index case was a child, no parent had RHD. And again, that's partly because the parents were older, and if they were going to have RHD, they'd already been discovered probably. Of the 111 sibling relationships, 12%, bless you, 12% screened positive for RHD. And of the 71 parent-child relationships where the index case was the parents, 15% screened positive for RHD. Now, I mentioned the Ugandan study earlier. Compared to the Uganda study, we had similar rates of RHD among first-degree relatives in our study. I'm getting the 5-minute mark, so I'll go a little more quickly. We next examined whether certain index case characteristics were associated with odds of having an FDR with RHD. Age, sex, socioeconomic status were not associated with likelihood of having an FDR screen positive for RHD. I've listed the data for sex here, and there was a suggestion that female index cases were more likely to have FDR screen positive, but the confidence intervals, as you can see, are quite wide. Similarly, with family history, a family history of RHD tended to be associated with a 5-fold higher odds of screening positive for RHD. But again, the confidence intervals were wide because of the small numbers of those who have a family history of RHD. So a number of limitations deserve consideration. Generalizability, our index cases receive care at tertiary medical centers, and that may indicate relatively more severe cases. Whether these findings are generalizable to other community settings is unknown. Selection bias, while we invited all the index cases to bring all their FDRs, only those average of 2.5 FDR per index case. So we're missing a lot of FDRs, and there might be some bias in who gets invited to come. If an index case preferentially brought family members who they were concerned about, this may lead to spuriously higher rates of RHD. And conversely, some came quite far, some traveled hours to get screened by us. And so if difficulty of travel allowed only healthier FDRs to get screened, the true association may be underestimated. We don't know which direction the bias exists in our study. We had no control group in our study, but that was by design. We weren't trying to see whether FDRs of RHD had a higher risk than FDRs of people without RHD. What we wanted to know was, is this a good screening method? And we had a limited sample size to explore the various subgroups that we were interested in. So, conclusions of our study. Our study demonstrated that screening FDRs of known RHD cases is a high yield method of identifying previously unrecognized RHD. Identification of FDRs with RHD can encourage these patients to receive earlier treatment with penicillin prophylaxis to prevent further reinfection and valvular damage. Coupled with the penicillin prophylaxis program, adoption of FDR screening into the national RHD screening strategy in RHD endemic countries like Nepal could improve RHD care worldwide. And just a couple of very quick other slides. There are a number of other ongoing RHD related activities. I'll just going to highlight a few. We've developed and piloted an innovative training program for a nurse-led RHD screening using echocardiography. Here's Becky Swagler, one of our UW sonographers, giving didactic and hands-on training for our Nepali nurses. We've established a registry of several thousand RHD patients. And we're developing a platform of randomized clinical trials of RHD interventions and therapeutics. We have a number of other research ideas that are now germinating and need to get into the grant writing stage. And we have a terrific team of committed investigators and team members, both here in the US and in Nepal, who've made this work a success. Everyone on this list needs to be highlighted individually, but in the interest of time, I'll only give a shout out to the people in this room. Annette, who introduced me to the work in Nepal, and she, along with Biraj and Archana, have really spearheaded capacity building in Nepal and created these truly amazing research resources that you heard Archana describe. Camila is my amazing study coordinator, and Soria is a master's student using some of this data, and a lot of the work that I've presented is Soria's master's thesis. And thank you.